Hi, everybody. This is the International Academy for Clinical Hematology around the globe and across the hematology field. I'm Mohamed Moti from the Sorbonne University and Saint-Antoine Hospital in France, and it is my great pleasure to moderate today this webinar dedicated to the management of elderly but fit multiple myeloma patient. And we would like to focus on the nursing perspective. This is part of the ICH for Nurses series. And like in previous webinars, I'm very fortunate and feel very honored having with me today Dr. Ceri Bygrave, Dr. Emma Williams, and we have a new panelist, namely Hannah Belcher, who is also a practicing nurse, and they are really expert in this field. And why did we choose this specific topic? Well, I believe it's a timely one, and some people may say it's fashionable, but in the last few weeks, we had really some novel and interesting results based on two major phase 3 randomized trials, namely the IMROSE trial, which has shown the superiority of a quadruplet regimen, cetuximab plus VRD versus VRD, but also the benefit trial from the IFM cooperative group, showing also that ESA VRD in terms of MRD is better than ESA RD. So my first question is to you, Ceri, and whether you can give us a sort of an overview about the evolution of the treatment of multiple myeloma in this so-called elderly population, or sometimes we call it non-transplant eligible or unfit, bearing in mind actually that in Western countries, the median age of multiple myeloma is around 70 or 71. So half of the patients are actually above 70. So what do you think, Ceri?
So thank you, Mohamed, and thank you to the IACH for inviting me. That point leads me straight into what I was going to say, which is we shouldn't forget the elderly because in actual fact, they are the biggest group. We know that myeloma is a disease of older patients. And as you say, certainly in the UK, the median age of diagnosis is around 70 years, which means the majority of our patients will be, if you went purely by age definition, not eligible for transplantation at diagnosis. And I think they're a group that has been sort of forgotten about perhaps for a long time, but now the situation is really improving and it's great to have this opportunity to discuss. So in terms of treatment evolution, I think it does reflect evolution of myeloma treatment in general. So if we went back 10 or 20 years, older patients normally received very simple oral alkylator and steroid-based treatments such as melphalan and prednisolone, cyclophosphamide and dexamethasone. But then as soon as the novel agents became available, they were added in slowly. So to MP, we added Velcade to make VMP. And to CD, we added thalidomide to make CTD. And certainly when I started in myeloma, they were fairly common treatments for older patients. I think it's only really in the last year or so, certainly in the UK practice, that things have improved beyond that situation. Where we work in Wales, we have actually been able to give a triplet regimen based on a proteasome inhibitor, an immunomodulatory drug and a steroid for around 2 or 3 years. We've actually been able to access IRD, ixazomib, lenalidomide, and dexamethasone first line. So that does reflect this evolution. We've dropped the alkylator, we brought in IMiDs, we brought in PIs, and now we can use them together. And that regime our patients tolerate very well. The rest of the world has been using VRD or VTD in an attenuated form for quite a while, but we don't really have experience of that here. But then certainly in the last year, we've really moved over towards DRD. So daratumumab, lenalidomide, dexamethasone. And again, that does reflect the fact that younger patients, fitter patients, are now getting monoclonal antibodies up front. Daratumumab obviously is a very effective drug for myeloma, and I would actually say it's also well tolerated for the most part. So that's kind of where we got to. But of course, all of us have seen the data from IMROS and BENEFIT, I think first presented at ASCO this year. And so perhaps if we just take some time to go over what those two studies have shown. As you say, in IMROS, the comparison was between the quadruplet of isatuximab VRD versus VRD. So the question in that trial, do the patients need the monoclonal antibody? Is there anything to gain by adding isatuximab, which is a CD38 monoclonal antibody, to VRD? And as you say, the results are quite spectacular. And although the median progression-free survival hasn't yet been reached, if the projections continue as they are, it could be somewhere around 7 years. And so for a patient diagnosed 70, 75, to be on the same treatment and stay in remission without progressing for 7 years is huge. We'd all want that for our patients as long as it's tolerable. And perhaps when we bring Hannah and Emma in later, we can talk about tolerability. BENEFIT asks a slightly different question. And the question there is, do they need the Velcade? So do they need the proteasome inhibitor? So the randomization is between isatuximab with VRD or just isatuximab with lenalidomide and dexamethasone, which I would say is very similar to DRD, which is now a very common first-line regime from the Maya study with a median PFS of 5 years. And obviously, BENEFIT is a little bit behind IMROS in terms of the maturity of the data, but as you said, it looks as though there is value from giving Velcade with the other 3 drugs to older patients. It does seem to induce deeper remissions, and we all know that deeper remissions usually last for longer. So I think that's a quick overview of how the landscape has changed. I think the question that we're trying to answer is, first of all, can older patients benefit from these drugs? And I think it's clear that they can. But then obviously alongside that, it has to come with the question, well, is it well tolerated? Is that benefit in terms of longevity matched with a maintenance or even an improvement in quality of life? And perhaps for the older patients, that's as, if not even more important.
No, thank you, Ceri. This is a very nice overview and summary. And actually, your comment about the fact that BENEFIT is maybe lagging behind IMROS in terms of follow-up. And indeed, IMROS was published with almost 5 years of follow-up. So it's a relatively long follow-up. However, now having MRD as a primary endpoint being accepted, actually, we could have released the IMROS data 4 years ago. So it's a very dynamic field. However, that's not our topic for today. So let me now move on to you, Hannah and Emma. And as you just heard from Ceri, is about not all so-called elderly patients are the same. So in your practice, because you're really in the front line, dealing with patients, I would say, and spending more time with them than the doctors, what are your practical tools to distinguish the relatively old but very fit, the very old and unfit, frail, and maybe in between, because one treatment will not fit everybody? I don't know who wants to start.
Hannah, you probably see them a lot more frequently in your general capacity. So maybe an overview from your perspective, and I can maybe then chip in with my trial hat.
Okay, yeah, fine. It definitely is a difficult question, and you certainly work out quite early on that age doesn't really mean a lot. You get patients who are very numerically young, but present as being much more frail. And so it really is a patient by patient basis. And sometimes it's trying to tease out conversations to find out what's really going on. Especially in the older generations, we find that patients will make a real effort to come to clinic and put their lippy on and make themselves look as good as they possibly can for doctor. And so they give quite a different perception of what they're capable of doing and how well put together they are, because they've put all their effort into making that look good for clinic. We run a weekly quality of life clinic where we follow up on some of these patients that we are a bit more concerned about, and that's when myself and my colleague Amy, we ask some of the more prying questions. So how do you do your laundry every day? Do you change your own bed? Do you get out and do the shopping? And that's when things start to come to the fore a little bit more about how people are perhaps struggling more than they would dare to admit, I guess. So it really is quite a difficult one to tease out, because you're relying on that patient report of what they deem they're able to do and what they're not able to do. And I often find it can be influenced quite a lot by what they think we're asking, why we think we're asking, and they'll perhaps try and present themselves as fitter so that they get what they think is the better treatment. They don't want a lesser treatment. If they find out that I need carers, are they going to give me, some vitamins and send me on my way? And we have had some patients recently saying, because I'm 80, are you giving me a lesser treatment and, just sort of patting me on the head because I'm old? Or, and I think that's part of the nursing process as well, I guess, is to try and help those patients understand that not having a transplant doesn't mean that you're getting second-rate treatment. And if, the data that Ceri's mentioned just now from IMROS, a potential progression-free survival of 7 years is not to be sniffed at, and certainly isn't second-rate compared to somebody who might go through a transplant. And it's kind of helping the patients to see that the reason we assess their frailty isn't so that we can decide whether they're worthy of treatment or not, but it's actually to give them the best treatment and maintain that quality of life. Because a progression-free survival of 7 years is great if you're able to live in those 7 years, but to be confined to bed and not be able to do the things you enjoy, it becomes a bit irrelevant, in my opinion.
No, thank you. That sounds very reasonable. Emma?
Yeah, I think what Hannah said was really pertinent with regards to when we're screening patients for clinical trials. If they hear about a new trial via clinic, they can present in a very different way to what they're actually, to how they are day to day, and it can be then us, as obviously we as a trial team, then intervene and go through the screening process, and we're constantly monitoring that did any deterioration in ECOG score, any deterioration in their frailty at that time, because they desperately want a treatment, and they desperately want all of the options available to them. But again, an important part of that process is educating them and saying, this is a trial. It's very, we hope that it's going to change outcomes, but it's not suitable for everyone. And I suppose working very closely with Hannah and Amy, and obviously the clinical team, to sort of continue and make that judgment as we go along. But yeah, it can be challenging.
Excellent, thank you. Something that rang a bell in my head when you said, Hannah, about the conversation. And there is something that maybe we are neglecting or underestimating, is the cognitive status of the patient. Because some patient may have like a fluid, normal conversation, but when you start digging deeper and deeper, actually, then you realize, is this something, and maybe Ceri, you may give the medical perspective there, whether it has an impact or not. How is this factored in your current approach?
Yeah, I mean, I think Hannah and Emma touched on some great points there. I think the extent to which patients hide things from doctors is underexplored. And I think a good level of cognitive function is actually important for understanding almost any myeloma regime. These things are very complicated, and patients can easily get muddled, more so with oral treatments. You know, we have to be really sure they know what to take on which days. I think there's a small percentage of patients that almost produce their own diaries, and you know that they're not going to mess up. But I think in between that and the people that we decide absolutely can't have oral treatment and could only perhaps have some subcutaneous Velcade and no more than that for obvious reasons, there is a mixture. And I think perhaps one aspect that myeloma nursing, myeloma research nursing could develop is more ways to support patients in allowing us to make sure they take their treatment safely and optimally, and also make sure that we are capturing actual dose delivery. Because your data can look wonderful, but if patients weren't compliant, if there was variation in compliance, obviously that might explain why some things look better than others. So Hannah, I don't know what your feeling is about that. I know we talk about this a lot all the time about diary cards and compliance, but you know, how big of a problem do you think it is?
I think there are quite a few different little problems in that. So obviously there's the compliance and dose monitoring and all of those things, and it's quite difficult sometimes to work out how a patient's going to manage with an oral regime when you first meet them, because as you say, they might have support there with them that they then don't have at home, or they say all the right things and nod in the right places, and then when they get home they've got all these tablets that they actually don't have a clue. We have had instances of people bringing back bags of meds saying, I didn't know what any of these were for, so I didn't take them. And you think, oh, okay, you know, you could have phoned us and talked about it, but they don't want to admit that they don't know what's going on, or somebody does their meds for them and they were away, things like that. I think also what worries me sometimes about giving certainly more frail patients an oral therapy and sending them on their way is we don't have that touch point of bringing them into hospital. If you're having an IV or a subcut therapy delivered by a nurse in the day unit or on the ward, you've got somebody with clinical eyes on that patient once a week, twice a week, once a month, whatever, that can really kind of look at them and make sure that they're doing okay. They can ask those questions about how are you managing and manage those symptoms. And you mentioned about early detection of side effects or toxicities and things like that. And you can get that when you've got those regular touch points. If you've got somebody who's not likely to put their hand up and ask for help, or can identify that they're struggling, you have to wait until you've got a clinic appointment, and then you've got to rely on them to bring that up to you, or to ask the right questions to tease that out of them. And I think that's one of the reservations I have about starting patients, particularly frail patients, on or patients with any sort of cognitive issues on an oral regime.
So I think that's a really great point. And Mohammed, maybe that this is an opportunity to discuss the scheduling that was used in IMROS and Benefit, because it is one area where perhaps it is possible to criticize or to examine the IMROS regime to say, okay, you're taking an older group of patients up to the age of 80 and you're giving them twice a week Velcade. And actually, just to deep dive into that, the way the Velcade scheduling worked is it was actually a 6-week cycle, and the patients came for bortezomib or Velcade day 1, day 4, day 8, day 11. Then there was a week's break, and then I think it was day 22, 25, 29, and 32. And one way of looking at is, my goodness, these patients are going to be in day unit all the time. On the other hand, you could look at it and you could say, okay, you're taking patients with a serious blood cancer who are that much older, and actually you're able to see them twice a week. You know, maybe that's good for patients. And of course, when you take the Velcade out of that regime, you'll then only be seeing them once a week for the isatuximab, which I think was weekly for the first 4 cycles, and then it goes to every 2 weeks for 18 months, and then it drops to monthly. And so perhaps when they're only on once a month isatuximab and then lenalidomide for 3 weeks out of 4 at home, is that when these problems are more likely to happen, and patients are more likely to struggle, because actually what older patients need is more observation rather than less. You know, if we had all the day unit capacity in the world and all the staff in the world, and these units were easy for patients to access and closer to their homes, it's actually quite hard to make a case that all oral therapy is the best for the patient. It's just maybe it's the one that we feel is easier to deliver because they're responsible for it themselves, but that responsibility may not suit everybody. I can see Emma's got a hand up on this one, and then Mohammed, maybe we could hear your thoughts about those points.
Yeah, so I just wanted to mention across all of trials which I've worked on, there's been a real disparity about providing the research teams with support to actually help the patients navigate through their treatment with regards to diaries. Even with commercial trials, I think there is a real lack of, well, you've opened the trial, it's your responsibility to make it work however best it works. And that is a real sort of disappointing, I think, for these such big companies, because this should really be factored in from a very early stage, and maybe considered within the contract, so that this is fully forecasted, because obviously these patients are on treatments for a long amount of time, and obviously their cognitive function could deteriorate, which it can do. So I just think that there needs to be more thought from the very outset of designing trials from a trial perspective, if there's any support to help us get this right, because I think that it is a real danger for our patients.
I think that's true. And I think one danger is to assume that older patients aren't tech savvy, so wouldn't use an app or don't want text reminders, and that isn't necessarily true across the board. No. In fact, some of the most eloquent emails, Hannah, we get seem to come from our 90-year-old contingent of patients wanting to organize their Lenalidomide around their travels. That's a wrong assumption to make. So I agree, more investment in that would be helpful. But Mohammed, I don't know what you think. Obviously in Benefit, the Velcade was once a week. Do you have any thoughts about how much these patients need to be observed?
Well, yeah, I mean, you read it very nicely, Ceri. There are some subtle differences between IMROS and Benefit. And actually, Benefit shows it clearly if we dig a little bit deeper into the results and the data, that actually you may not need Velcade bortezomib after 1 year. So that's already good news. However, in IMROS, when you calculate the number of injections of bortezomib, actually you have less than in Benefit because of this long cycle. And that brings me to something you all three said, and that sounded like music to my ears, is that historically there is this common belief that if you are old, you need oral therapy. And I'm 100% convinced that this may not be true in the majority of the cases. And on the other hand, now with the complexity of the treatments and combinations we're giving, with sometimes some unexpected potential side effects, actually having systemic treatment is more useful, because also, you nicely mentioned that some 90-plus-year-old patient are very good geeks, but still, not all patients are equal. And I feel more and more in our daily clinic, we're asking the patient more and more, and they are struggling on how to navigate the technicability and the sophistication of everything we do. And this is why I'm very grateful to all our nurses spending hours and hours explaining everything, because the patient will spend with the doctor 10 minutes, and to their any question, the answer is, okay, thank you very much, etc. And then they just move next door and spend a couple of hours, complaining. So this is why I like the idea that coming like every month to the clinic on the long term, especially if you are 75 or 80 and you may be struggling with another disease, you want to renew your prescription. Actually, it's not so negative, in my opinion. But that brings me actually to the issue, because this is all about, and one of the key features of these quadruplet regimens is that they were confined and mainly used in fit patients, because obviously the secret in this so-called elderly population is to keep them on treatment as long as possible. So you don't want to have a toxicity, a safety issue emerging quickly because of this or this comorbidity. And then if you stop the treatment, then obviously this is where this will lead to a worse outcome. So here my question to Hannah and Emma, how do you, assuming a patient is now taking whatever combination, let's say ESA, tuximab, VRD, and how do you manage these patients in terms of early detection of safety issues? I guess this start with education, but then there are, I think, some good tools to anticipate. Emma, you may wish to start.
Yeah, I think from a research perspective, obviously safety is key for everything that we do, and you know, we're very much observing I suppose it's more concentrated how we're doing it, and we've got sort of checklists that we follow as to patients, you know, developing toxicities. So to us that is part of the course of what we do anyway. So but it can be very intense at the beginning, you know, because the patients obviously are settling into a regime, and it can be sometimes they ring daily, you know, throughout the week, just wanting that reassurance. Maybe the text on the phone will go off, just, am I doing this right? And it's just having that relationship with our patients, and saying to them that it's normal for them to feel like that and feel very scared about what they're doing, and to check with us if they're doing things right. So I think it, you know, it can be quite time consuming, but it's very important to be on it and capture those toxicities as soon as we can, because if we can reverse them, then the sooner the better.
Hannah?
Yeah, I think, again, it comes down to how much the patient's willing to divulge, I suppose. You've got those patients that will be messaging you daily, and they're the ones I worry about less, actually, because you know exactly what's going on with them. It's the ones that disappear off and are very quiet that you worry more about, because are you not phoning me because everything's fine, or are you not phoning me because you don't want to bother me, or, you know, there's a lot going on. And I think sometimes that relationship, the nurse-patient relationship, is also different for every patient. We said every patient isn't the same, and I think that's the same for the relationships you build with them. And there are some that will walk in and say, I will do whatever you tell me to do because you know best. And there are others that will not trust you. And one patient in particular comes to mind. In fact, it's the patient who said to me, you know, because I'm 80, are you writing me off and just giving me some vitamins and a pat on the head? And I've said to her, look, trust takes time to build, and I think this relationship's going to be one that takes time. But now that she's into her 4th cycle and she's seen the graph that her disease is going, and she's feeling better in herself, I go, aha, now you're going to trust me, and we can have a bit more of an open conversation about how you're feeling. Because it does take time sometimes for these people to realize that you're on their team. And you're not looking at them as going, oh, you're old and frail, we're just going to put you in a box and over there, because you're not our primary concern. But I think once the patients get to know you a bit better and see that actually the things we're doing are fighting for you, they're a bit more open, and then they will share with you things like, you know, actually, come to think of it, my fingers don't feel the same, or, you know, I have got problems with my bite or my teeth, or, you know, so we do have checklists in the day unit. We have a checklist before they have any cycle of before they have any chemotherapy, to make sure that we're checking on those toxicities and if they're better or worse than last time, and if it, you know, so we have got those checklists in place. But again, I think it's based on the relationship you then have with the patient as to how much information they will give you. And sometimes about the way you ask questions to people as well. I know that sometimes there's a particular bortezomib checklist to say, you know, have you got altered sensation in your hands and feet? And some people think, well, no, not really. But then you ask them, can you open a bag of crisps? They go, oh gosh, no, can't do that. You think, okay, there is something going on here. And it's getting to know how that patient is going to communicate with you. So it is, I must say, the girls on day unit do it brilliantly, but it is a bit of an art form more than just a checklist on a piece of paper. It can be
I
quite
find
subjective.
the neuropathy assessments quite challenging, and obviously I've worked on in the specialities for a long time, and it's just, you know, making them really be specific with what it actually is that is causing you problems, you know, because they'll try to just get through the treatment. They want the treatment that day, and they just want to get through it any way they can. So it's really putting a fine point on those symptoms.
And sometimes they'll wait, won't they? They'll wait till
Yeah.
they come in for their treatment and say, oh, by the way, for the last 4 days, I've had awful diarrhea and vomiting. I haven't been able to get off the toilet until today. And you're thinking, why have you waited till today to tell me? Why didn't you phone me earlier? And they don't want to be a bother. I don't want to be a bother, but they don't realize that actually we can make life better by tailoring those treatments.
Yeah.
So that brings me to the question about the use of all of these telemedicine tools, because since the COVID pandemic, we've seen clearly the advent of telemedicine, and now we have patients who prefer not to come, but rather to be followed using some of these softwares or whatever. I will not use brands for the different softwares and tools. Is this something that you believe is going to be more and more implemented, and in between cycles, in between infusions, injections, can allow really to optimize the follow-up of the patient?
And I think, you know, we would love an app for our patients. You and I feel the same way about that.
Absolutely.
I think what we would be looking for is a data system that is both responsive and has a trail and can be analyzed, because I totally agree with everything Hannah said about this is an art, but it's very hard to quantify an art, and it's very difficult to design the ideal treatment protocol based on what is essentially qualitative data. So, you know, we've got 2 studies. One gives 1.3 milligrams per meter squared of bortezomib twice a week for 4 weeks out of 6, and the other one gives weekly in a 4-week cycle. And if we could drill down into all of those people's reported peripheral neuropathy using exactly the same descriptors and decide and define the optimal protocol using an app, that would be great. That would be ideal. And until we're at that point, actually what we'll have is a collection of systems that do that to a certain degree, but not in a uniform way. And that's why there is variation. Hannah, I don't know what you think about how practical that would be. I'm sure it's something that we'd all like to do.
Absolutely. And I think a lot of the data that we've all got checklists that we fill in pre each dose to monitor, you know, like I said, we monitor whether the things are getting better, worse, staying the same. But we don't have that data at our fingertips that we can then pull to go, oh, look at what happened over time. I suppose trials might have more access to that kind of data analysis. But certainly in the sort of more general practice, it's on paper. And so short of me going and trawling through the patient's notes and making a tally chart, we don't have that data to use to, I suppose, to justify. You know, if we're looking at a financial view, which isn't a particularly nursey thing to do, but if we're looking at giving somebody a quadruplet rather than a triplet, that's an added cost. And to prove cost effectiveness, you need some data to show that actually patients aren't suffering and that patients are living longer and having a better quality of life, which, you know, thank you for the trials team and for things like IMROS trial that do attempt to show that. But there is that real world data that's missing. And, you know, we mentioned that this trial is about the elderly population that are fit. and that's great, but there's a huge elderly population out there that aren't very fit. And where do they sit in this kind of dynamic of which treatment is better? We've already debated, is it better to bring them into a hospital environment, or is it better to give them an oral therapy at home? But we don't really have the data in front of us now to talk about the real world data of what's actually happening to the real world population.
It's a great point, and it's so nuanced. The general heading that frailty is dynamic could actually be a topic for an entire webinar in itself. But yes, in that you've touched on the fact that drugs can induce frailty because neuropathy can, let's say, increase falls risk, etc. And then that brings with it risk of hospitalization and increased care demand, etc. On the other hand, myeloma is a frailty-inducing disease. And so if you have a highly effective, tolerable quadruplet that can get people into remission and keep them there, then does that make their frailty go down? You know, those are the actual things that I would like us to be better able to quantify. And I think longevity is an indicator of success. You can't deny that it is.
Yeah.
But the additional cost or saving that goes with it would add to the quality of the data and the richness of the data. Emma, I don't know what you think.
One thing for sure, IMROS actually, and this is quite unique, assessed quality of life, and the quality of life, despite coming for an IV injection, actually is similar.
Yeah.
So, and this is likely, as you said, Ceri, probably because we have a better disease control, rapid disease control. So we're healing the symptoms, so they're feeling better. Emma, you wanted to add something?
Yeah, only that this is where nurses, being investigators and leads on research studies, can really make an impact. So there is that real world data that is missing, as we say, and what's stopping nurses who are not in research to answer those questions with the support of their research colleagues. And this is something that we've done quite well in Cardiff in the last few years. Is people have come to the research team with specific questions around their patients, TYA team, different questions that have remained unanswered, that they haven't been able to look at, with nurses coming in and saying, I would like to ask that question, and how can we do it? And then the research team would navigate them through it, and then we can look at these questions. So I think this is a perfect example of answering a nurse taking the lead on a question and really changing that mindset.
Wonderful. Thank you, Emma. We're almost at the end of this webinar, so I have one question to all of you, same question. What are your hopes, or what kind of things you want to see improving when it comes to the management of these patients now receiving combinations more and more highly effective? So where is the unmet need in your opinion? Because obviously we heard the PFS data are amazing, safety is great, the quality of life, patient satisfaction is there. But I always believe that there is room for improvement, and until we have cured all patients, we still need to improve. So from your perspective, where are the areas where we need to continue to investigate and invest? Hannah, you want to? Yeah, Ceri?
Yeah. Oh, Hannah, go ahead. Yeah.
If anyone knows me, they probably know what I'm going to say, but I think we've talked a bit here about data collection and data processing, and I think that's something, with Ceri and Emma will agree that data is wonderful. And I think that question could be answered if we had our fingertips on that kind of data. If we have real world data of how patients are experiencing these medications, of what they want, of what they are asking for. We've made up our own sort of assumptions here today on whether we should bring them into hospital or whether they'd prefer to be at home, but really the only person who knows that answer is the patient. And there is obviously hope hopefully one day maybe a happy medium of having treatment closer to home, not in the big hospital where there's problems with parking and traffic and all of those things. So I guess my answer was kind of twofold there, that I would like treatment closer to the patient, but also I'd like that data to be able to pull out what it is the patients are asking for.
I think that's fair enough. We are all advocating and asking for real world evidence, real life data, because obviously the clinical trials are great to establish a standard of care to get approval, but then we need to figure out how does this behave in routine practice. Emma?
Yeah, I just think that this is a really good opportunity for a collaborative approach. Research isn't just the research team, it's the whole team. And, you know, sometimes our CNSs can feel a bit put out, you know, when we take the patient over and then they don't see them because we're doing all the research bits. But this is a perfect question that needs answering, and I think having that collaborative approach and thinking outside the box for these real world questions is the way forward.
Okay, thank you. Ceri, you have the last word.
Yeah, okay. So, I mean, back to what we started with, really, the treatment of older patients has evolved, and older patients are now enjoying a first progression-free survival, which, as Hannah mentioned, is almost better than induction, transplant, lenalidomide maintenance in some cases. So we do seem to have cracked that in terms of finding regimes that can be very effective. I think if patients had a wish, it would be for more steroid-free regimes, for example. So, you know, we can talk about whether patients need a monoclonal antibody or whether they need a PI. How much steroid do they need? And when can we drop that from older regimes? I think that would be really helpful and popular. And then back to what both have touched on, really, where is the opportunity to make treatment more patient-friendly? Once we've grasped the idea that older patients still want a cure eventually, they still want a long, deep response, but how can we make that available at minimum cost to them and their family and their quality of life?
Wonderful. And that makes me think that we need to organize something around management and of side effects and management of steroids, but also maybe dose adjustment, duration of cycle adjustment, the practical things, because in clinical trials, the reasoning is on an intention to treat, but the devil is always in the details. But for the time being, I would like to thank you, Ceri, Hannah, Emma, for sharing your experience, your knowledge, your wisdom with the community. I really enjoyed it. I learned from you, and it's really a fascinating period, and progress never stops in multiple myeloma. And actually, this is really bringing a lot of hope to a patient. So wherever you are, please stay safe and keep well. Thank you for following the ICH.